In the previous section, we have discussed in detail on the clinical features of tuberculosis, but in this particular section, we are going to discuss in detail about the workup and diagnosis of tuberculosis. But before going to the actual workup and the diagnostic methods of tuberculosis, it's very, very important to understand what are the strategic plans that are made by the government and what are the paradigm shifts that are happening in these strategies to stop the deadly disease. And currently, we are running an elimination plan that's called NTB 2025 by Indian government. So accordingly, you have to make the changes in your diagnostic and treatment plans also. So that's what you're going to see in the first place before going into the actual working up process. So in 2012, the first national strategic plan was announced. That's called 2012 NSP. And accordingly, in that, they gave some goals because you have to understand the history to know what is going to change in the future. So that's why I'm telling the history in the first place. In 2012, what happened and what was the targets that was set. The notification of TB is of very important thing because everyone should know how many TB cases are happening and the government should have a data on how many TB patients are there in the country. Then only you can eliminate the TB successfully. That's why they planned a target notification of approximately 90% for all cases, at least minimum. And then they have set a success rate for treatment. So treatment success rate for new cases, they set a target of 90%, and for retreatment cases, they have set a target of 85%. Then they wanted to target two special population. One is the drug-resistant TB cases, where they wanted to improve the successful outcome, number one. Second group they target is the HIV-associated TB cases, that is HIV-TB co-infection cases, where they wanted to decrease the morbidity and mortality. Number 4. Fifth one, so they wanted also to improve the TB outcome in the private sectors also. To improve the TB outcome in the private sectors, so they targeted the private sectors because this is a large heterogeneous group. Like private sector is not like a homogeneous body. Each and every hospital acts like a different body in the private sector, at least in Indian scenario. So it's not easy to unite all these practitioners together and make them notify this disease to the government. At the same time, it's not easy to make a uniform treatment in the private sector also, because each and every practitioner in India acts like a separate practitioner, separate body of evidence. They don't work along well with each other. So they want to target the private sector in the first place. So private sector wise, what they did is they passed a GO in 2012, where they made TB a mandatory notifiable disease. So TB is a mandatory notifiable disease. You have to notify TB no matter what to the Indian government. So this is a rule that is passed. This is a government order, so you cannot disobey that. So this is one way to make the practitioners notify the TB to the government, and to make it simpler, because they cannot go to a setup or they cannot travel to an area to notify the TB, and it should not be a cumbersome process. That is why they've announced a software called Nikshay, and now Nikshay is like giving a lot of purposes to even for patients also, but initially it was designed for notification purposes. This was first installed in 2012. It's a web-based software and web-based application, Nikshay app, where you can actually notify the TB cases uniformly in both public as well as the private sector. So these are some of the approaches to make the TB much better notifiable, especially from the private sector group. So these are the strategies that was made in 2012. But what are the strategies we made in 2017? So we are going to see about the revised targets. These are the revised targets in 2017. And this is the plan for 2017 to 2025. This is the next national strategic plan, 2017 to 2025. So currently, we are running a program called NTB campaign, that is called NTB 2025. But remember, WHO plans to globally eliminate TB by 2035. So that's WHO's plan, globally eliminate TB by 2035. But India, little ambitious, but still India tries to eliminate TB by 2025. That's called NTB 2025 plan. And what are the targets and visions of this NSP 2017 to 2025? So first let us see the vision. Vision is TB free India. That's the first vision with 0 deaths. You should not have any death related to TB to bring down the mortality almost to 0. At the same time, with 0 poverty due to tuberculosis. Remember, if a disease like a TB strikes a patient's family, and the patient is not only going to suffer health-wise, they are also going to suffer financial-wise. So that is also a goal, to make zero poverty due to tuberculosis. That is one of the vision. And second, you have a goal also. You have to achieve a rapid decline in the burden of the TB. So decrease the burden of TB in a very rapid way. At the same time, to decrease the morbidity as well as mortality. At the same time, you also have to achieve the end TB or eliminate TB by 2025 target also. So these are some of the revised targets. But accordingly, even though I told the vision and the goal, you should translate into metrics. That is the numbers. You need the numbers. You have to show the numbers, then only it is acceptable. It's in any corporate, you know the metrics and the targets. Like that, the government also has their own metrics and the targets that you have to prove upon. So let us see some of the metrics and the numbers that we set as a goal. So 2015 value is set as the baseline for the NSP 2017 to 2025. So we set the 2015 values as the baseline value. So what should we achieve by 2020 and what should we achieve by 2025, and what is the goal here? Which means I can tell is comments, but this is actually the goal. This is what you have to prove. So first one is the reduction of the TB incidence rate. Reduction of the TB incidence. These are called as impact indicators, and we have outcome indicators also. First, let us see the impact indicators. Impact indicators, reduction of the TB incidence is the first goal. Remember, since 2015 is set as a baseline, so in the 2015, we had TB incidence of 217 per lakh population. The goal by 2025, this is the date of goal. So at that time, we try to achieve decline in incidence by at least more than 80%. From this particular 2015 value, by 2025, we have to reduce it by at least more than 80%. By this definition, it has to be in the range of 44 per lakh compared to 217 per lakh in 2015. In 2020, an intermediate target is set, that is 142 per lakh. And similarly, you have to reduce the TB prevalence also in the community. So the prevalence in 2015 was approximately 320 per lakh population. And this also has to be reduced by more than 80% by 2025. That's the goal. So by this definition, by this goal, you should have less than 65 per lakh cases of tuberculosis prevalent in the country by 2025. In 2020, the target will be less than 170 cases per lakh population. Similarly, you have to reduce the TB mortality. So TB mortality in 2015 was 32 per lakh population, and the goal is to reduce this by at least more than 90% by 2025. By this, you should reach a target of less than 3 cases death per lakh population due to tuberculosis. In 2020, it will be 6 per lakh. That will be the goal. Similarly, you have to achieve that zero catastrophic cost, which means the poverty due to tuberculosis in a particular family should be zero. That's called zero catastrophic cost for affected families. Right now, in 2015, it is only 35%. In 2025, it should be 0%, which means it's a zero goal by 2025. That's what you have to achieve, which means there should not be any poverty. Right now, the TB affected families, the catastrophe rate is approximately 35%, but 2025, it should be 0%. And in 2020, also we target a catastrophe rate of 0%. It should not be there by 2020 itself as per our target. But in 2025 is the maximum time where you should achieve 0% by the current goals. Then we have outcome indicators also. So what are the outcome indicators? So the number one outcome indicator will be offering drug sensitivity to notified patients. So whether all notified patients are offered with drug sensitivity testing to identify resistant tuberculosis. Remember, The goal is to achieve universal DST for all patients by 2025. Universally, you have to achieve drug sensitivity testing to all patients, all notified cases by 2025. By right now, it is only 25%, which means only 25% cases are offered drug sensitivity testing as of now, in 2015 at least. In 2020, we are planning to increase by 80%. You know, since it's universal is the target by 2025, it should be 100%. All the patients should be offered drug sensitivity testing by 2025. That's the goal. And notification of patients on treatment, patients on anti-tubercular therapy, which means whenever you initiate a treatment, what will be the notification rate. So here again, we are planning to increase as much as possible the notification rate, but to reach at least 95% is the target. So overall 95% reaching is the target in 2025. Right now it is approximately 90%, and we are planning to reach 95% by 2020 itself. By 2020, by at least 2025, it should be 95% minimum. And what about the active case finding? This is a big and a huge paradigm shift as of now. Please note the fact that active case finding right now is 0%. Remember, till now, all the RNTCP guidelines that have been framed, all the plans that have been framed are based on the passive case finding only. We never attempted to do a active case finding. But WHO released a paper clearly telling that if we don't treat this latent TB case and if we don't actively find the cases, TB can never be eliminated, because that will be silent and residing in a lot of population who are not going to access to the healthcare properly at all. So you cannot eliminate TB, especially in developing countries. So that is why by 2025, active case finding should reach 100%, at least for high-risk people. At least for high-risk population, your active case finding is a must, mandatory, and government is targeting to achieve this 100% active case finding rate. This is a huge paradigm shift. Like, I don't know how to explain. Like from passive case finding, now you are trying to completely change to active case finding. This is something, a huge paradigm shift. You have to know that definitely. By 2020 itself, we are planning to achieve that by 100%, the active case finding rates, at least for high-risk population. So this is going to be the most important of all the indicators I have told you. This is the huge paradigm shift that has been happening in the guidelines. So then what about the treatment success rate among the notified case of TB? So that is also an indicator. So we are seeing the treatment success rate among the notified cases. Obviously, like when you increase the notification rate, definitely this also will become easier to capture, the data at least. So what will be the treatment success rate? Right now it is 75% among the notified cases. This is for drug sensitivity TB, drug sensitive TB. Clear? We are not talking about drug resistant TB. This is for drug sensitive TB. What is the treatment success rate? 75%. But in 2020, we are planning to achieve 90%, and in 2025, we are planning to achieve at least 92% of treatment success, at least in notified drug sensitive TB cases. Then treatment success rate for drug resistant TB also should be notified. It should be captured. So right now, the treatment success for drug resistant TB patients is only 45%. We are planning to achieve at least 65% by 2020 and at least 75% by 2025. So these are the targets. In this, the most important points will be these points: how much reduction in the TB incidence and prevalence, and how much reduction in the TB mortality, and how much will be the catastrophe rate because of tuberculosis. So these are the 4 things are your probable exam questions. Maybe the numbers, I don't know much, but probably this 4% at least you have to know. Okay. Next, this active case finding, definite question. At least in one exam, they might ask you this 100% by 2025 active case finding, and by 2020 itself, you have to reach 100%. So this is a huge paradigm shift. I told you, you have to note that. And probably finally the treatment success rates. So these 2 numbers are also a little bit important. So these are some of the numbers that you have to note for exam, but I feel the most important will be these numbers and this particular number. Clear? So this is what is going to be the most important for your exam. Apart from that, anything can be asked in this, but I told you everything, but these are something which is Very important to know. The next one, what we are going to discuss on the detect strategy and the prevent and treat and build strategy. So this is the strategic plans that have been formulated to achieve these goals. So we are going to see on the strategy of how we are going to reach these numbers and metrics. So that is what we refer to as something called a DTPB approach. What do you mean by DTPB approach? It stands for the acronym Detect, Treat, Prevent and Build. So I'm going to tell only the new things under each of them, because a lot of old things have been polished and replaced in the new one. But what are the real new things? That's what we're going to see. And that's what are going to be the exam questions also. Detect, treat, prevent and build. In that, let me tell you about the build initially, because there are a lot of new paradigm shifts that have been happening and the new targets have been set. It is a must and essential thing to restructure the entire RNTCP management structure. So restructuring of RNTCP is the most important new point that has been included in the build strategy. Then we'll move on to the detect strategy. So what are the things that are new under the detect strategy? Number one, the two important populations that are going to continually transmit the cases to others are the one is your undetected TB cases who are not detected actively and they are residing somewhere in the country and they are going to keep on transmitting the TB bacteria to other people. And second one is these people who are going to have drug-resistant tuberculosis, because when they have drug-resistant tuberculosis, even during the treatment phase, the drugs what you're giving are not going to work, and definitely they'll be keeping on transmitting the disease to other people, and it will be even more problematic because it's a drug-resistant bacteria. So how to address these two things? The most important is to offer the drug sensitivity testing to all patients, the DST to all patients. That's a very important strategy, because this is the only way to identify these drug-resistant TB cases very early in the course of the disease itself, so that you can reduce the transmission by giving appropriate drugs. And second one, active case finding, because this is to detect the undetected cases previously because of no active case finding. So we are installing the active case finding strategy, which the importance of this I've told you already. Then you have the treat strategy. What do you mean by the treat strategy? What are the new things under this? First one is following the universal daily regime, which means if you are a practitioner anywhere in the country and any corner of the country, do not practice any other regimen apart from the daily regime, which means the previously followed thrice daily, twice daily and whatever regime you're going to give is going to get completely outdated and it is abandoned completely. So revert to the daily regime as of now. That's what we call universal daily regime. And we are planning to give social support to the patients who are suffering from TB, and their adherence has also to be monitored. That's called adherence monitoring, and you have to reduce the cost, and this has been there for a long time. Any patient who visits the public sector for ATT, they are going to get these drugs for free. There's no doubt about that. So giving the drugs for free of cost, reducing the cost and the burden on the family. At the same time, there's a new thing that is introduced, nutritional support, because the sound nutrition is also very, very important for fighting the disease, at the same time improving the overall outcome on the patient side. So that is why all these things have been implemented. What are the new things in the prevent strategy? In the prevent, the first thing is to treat the latent TB cases, because this is a WHO statement that came in 2009 and 10. In any developing country, unless until you treat these latent TB cases, your TB incidence will never become zero. You cannot bring down the transmission rate to zero. It's impossible to achieve that zero rate, because this latent TB case at any time, they might become active TB and they will keeping on spreading the disease. So you have to treat the latent TB case. As of now, we have started to identify the latent TB cases, especially in those people who are contacts of the TB cases. Clear? So those are the people who are at high risk of getting latent TB, and those are the ones who are targeted first in the current NSP. So treatment of latent TB is again a very big major paradigm shift. Previously we are not doing that, but currently yes, we are doing that. We are going to do that at least. And next, decreasing the airborne transmission. How we are going to reduce the airborne transmission? For example, at all healthcare facilities, you have to make this N95 masks available. Some example I'm telling you, like this, you have so many plants are there, but again, this is a long way to go. In every healthcare facility to make N95 masks available is not that easy task. But anyway, we are planning to do that. So N95 masks at all healthcare facilities. That is one of the strategies to reduce the airborne transmission and to improve the control of transmission. So this is what we refer to as something called a DTPB approach, and this is something very important to understand because I've highlighted only the new stuff. What are the new things? Only those things I have highlighted here. So with this, we'll move on to the ever important case definitions in tuberculosis. Case definitions in tuberculosis. So there are some changes in the case definition, especially with regards to the pulmonary TB case definition. So I'll be telling you the previous guidelines, then I'll be moving on to the current guidelines because that change, what they have changed is also very important to understand. Then only you will have an interest towards learning all these things. So first, let us see what will be the previous guidelines and what will be the current guidelines. Clear? First one is the presumptive pulmonary tuberculosis or a presumed pulmonary TB. So what is the case definition for a presumed pulmonary TB? First one, any individual with cough for 2 weeks or more. That is the first definition. Second definition, any individual with cough of any duration, doesn't matter, provided if the patient is HIV positive or provided if the patient is a contact of a smear positive TB case, contact of a smear positive TB case, or any patient who is having signs and symptoms of extrapulmonary tuberculosis or suspected or confirmed extrapulmonary tuberculosis. Clear? So if you have cough of at least more than or equal to 2 weeks or cough of any duration, plus if you have any one of this, like if it's HIV positive patient with cough of any duration or contact of a smear positive TB case of any duration or any signs and symptoms of extrapulmonary TB is there, and those patients, if they have cough for any duration, these patients can be taken as a presumed pulmonary TB cases. But the current definition, there are some changes are there. The first thing tells you cough more than 2 weeks duration. Second, fever more than 2 weeks duration. Third, if the patient is going to have significant weight loss. Let me tell you later on what is going to be the definition of significant weight loss. Next, any patient with hemoptysis or any patient with any abnormality in the chest X-ray, any kind of abnormality. I told you TB can produce any kind of abnormality, especially in countries like India. So any chest X-ray abnormality will be taken as a presumed pulmonary TB only. So if any of these things are present, you can take it as a presumed pulmonary TB as per the current definition. Understood? And they have also proposed a separate list for which patients should be screened for these symptoms, which means you can screen for these symptoms actively and you can ask for these symptoms and you can screen for these symptoms whether it is present or not in certain targeted high-risk population. So you can screen for these symptoms, but who? Who has to be screened? That's the question. So who can be screened? Means number one, this patient who is a contact of microbiologically confirmed TB cases. Microbiologically confirmed TB cases. Second, patients who are suffering from HIV. Patients living with HIV or HIV positive patients. Third, diabetes. Fourth, malnourished patients. Fifth, cancer patients. And fifth, patient who's on immunosuppressive therapy. Immunosuppressive therapy or medium to high dose steroids. So these are the patients who can be taken as high risk patients, and in these patients you have to regularly screen for signs and symptoms of tuberculosis, and if any of this thing is there, you can take them as presumed pulmonary tuberculosis case. Clear? Very important point. So this is the current definition and you have to know all these things because these are all questions in exams. Number 2. What is a presumed extrapulmonary TB case? Remember, there is no change in the current guidelines and the old guidelines. This remains the same. Extrapulmonary TB case is defined as any patient with constitutional symptoms and if they have any organ-specific symptoms that are suggestive of tuberculosis. So what are the constitutional symptoms? You know that your famous fever, night sweats, weight loss, if it is there. Along with that, if you have any organ-specific symptoms like swelling of a lymph node, cervical adenitis, probably they might be having chronic arthritis of the knee or hip joint, tuberculous arthritis there you're suspecting. Patient coming with cranial palsy, altered mental status and neck stiffness, suspected TB meningitis. So all these patients will be taken as a presumptive extrapulmonary tuberculosis or a presumed extrapulmonary tuberculosis. And there is no change from the previous guidelines. Third one, we have presumed pediatric TB patients. Mainly called a presumed pediatric TB patients. And compared to the previous guidelines, there is a little change is there. Some small change is there, especially on the weight-based definitions and all are a little bit changed. So that's what we're going to see. What are the presumed pediatric TB as per the current guidelines? Number one, fever, which is persistent in the child. Second one, cough more than 2 weeks. And third one, if the child has weight loss. What is defined as weight loss in the child? Anything more than 5% loss. And you should compare this weight with the maximal weight in the last 3 months. So whatever is the maximum recorded weight in the last 3 months, you should compare with that. And if comparing with that, you are having more than 5% weight loss, so that patient, you can take it as a presumed pediatric TB. Then if the child doesn't show any weight gain at all, especially in the last 3 months, this is the definition. So no weight gain in an actively growing child is equivalent to weight loss only. So that is also presumed pediatric TB. Then if a child has a history of contact with any infectious TB case. So by definition, any form of active TB in the last 2 years. So this will also be taken as a presumed pediatric TB only. So these are the 5 points that you have to remember. Fever for any persisting fever, they are not given the duration, but any persisting fever, cough for more than 2 weeks, or the child is having weight loss defined as more than 5% weight loss compared with the maximum record weight in the last 3 months, and no weight gain in the last 3 months, that is also equal to the weight loss in a growing child, and any history of contact with the active TB case in the last 2 years at least, or any form of infectious TB. If there is a contact, that is also taken as a presumed pediatric TB only. So these are some of the case definitions. Number 4, you have also definition for a presumed drug-resistant tuberculosis. So what do you mean by a presumed drug-resistant tuberculosis and what is the definition for that? So point number 1, patients who have failed first-line ATTs, and definitely if they are going to fail the first-line ATTs means there must be some problem with the sensitivity. So that is why these patients are 100% taken as presumed drug-resistant TB. Second, people who have already received treatment in the past, TB treatment in the past. Definitely if they have received treatment in the past means there is high chance of having a drug-resistant TB in the current timeline. Because it could be a relapse, or it could be a failure of treatment, or it could be even a defaulter. So in any of these cases, the risk of drug-resistant TB is going to be extremely high. Number 3, if the patient is having HIV-TB co-infection, this is one of the high risk factors for developing a drug-resistant TB, HIV-TB co-infection. And next thing, if the patient is a contact of a drug-resistant TB. Contact of a drug-resistant TB. And again, this is very important. Why? Because if you are a contact of drug-resistant TB, if you get a TB, that tends to be obviously drug-resistant as well, because the same bacteria is getting transmitted to you. Next, suppose if the patient is having a smear positivity even after treatment with the first line, that's equivalent to failed treatment only, but it may not be really failed. But if the patient is found positive, that is smear positive, found sputum smear positive anywhere during the treatment with first line ATT. So this includes if the smear is persistently positive, or if the patient has become smear negative and after that some point of time they have again become a smear positive. So this is the meaning of that is this only. Like if the patient is persistently smear positive with first line ATT, or if the patient initially has become a smear negative and they are continuing to take the drugs, but at some point of time again they have become smear positive. So that's the meaning of this point. So these cases are the ones which will be taken as a presumed drug-resistant tuberculosis cases. Clear? So now we have completed the case definitions. So now you know all the case definitions for pulmonary TB, extrapulmonary TB, pediatric TB, and drug-resistant tuberculosis. Now we are moving on to the diagnostic tools. Workup and investigations. So what are the diagnostic tools? There are three basic diagnostic tools that is going to help you in diagnosis of tuberculosis. Number one is your standard smear techniques, which is a time tested, and we are having a lot of experience. We know the advantages and disadvantages of this testing very well. So first is the smear. Second one is the rapid molecular tests, which include the GeneXpert and line probe assays. And the third one is the culture-based test. So culture-based tests are the ones that are going to be the gold standard. And the biggest advantage of the culture-based test is the fact that it can differentiate between live and dead bacteria. But this is the biggest disadvantage of these two tests, where they cannot differentiate between living and dead bacteria. Even if these tests show AFB bacillus, or if the GeneXpert picks up Mycobacterium tuberculosis, it is not a surety that it should be a living bacteria. It can also be a dead bacteria. Clear? So the first point. Second, let us move on to the each and every individual testing methods. So first is the smear technique. We have two types of smear testing. One is the traditional Ziehl-Neelsen type of technique, and second one is the fluorescent LED testing. Fluorescent, that is, we are going to use auramine LED stain. So this Ziehl-Neelsen technique, you know, they are going to use the property of acid fastness of the Mycobacterium tuberculosis. So they are going to detect the AFB. So what are the advantages and what are the disadvantages of the traditional smear testing? Number one, the biggest advantage is it is specificity. If you detect, it's very highly specific, 96 to 99% specific. At the same time, its cost is very, very low. This means very cheap. You can implement this in any situation. And third thing, it's very rapid, which means it's very fast and the result can be dispatched within a few hours. Especially if you are able to pick up this in a high volume center. But this is going to suffer from a pathetic disadvantage. That's a huge disadvantage, in fact. That is a low sensitivity. And certain trials have shown a very, very poor sensitivity of at least only 50% in this smear techniques. This sensitivity is going to fall even further if the patient is going to be HIV or a child. So in a pediatric population, or if the patient is HIV positive, the sensitivity is even more pathetically worse, and we are not going to use this testing at all in this patient. That's why in this population, we are going to use the GeneXpert as the preferred modality. Clear? And what are the advantages of this fluorescent staining? In the fluorescent LED stain, the only advantage is it picks up that extra 20%. That extra 20% is picked up. That's the biggest advantage in this fluorescent LED stain. So which means the sensitivity may slightly improve to approximately 70%. That extra 20% is picked up better by this fluorescent LED stain, auramine staining. But overall, the entire smear's sensitivity will increase if the patient is having a cavitatory lesion. So if there is a cavity in the lung, or if you're taking sputum from a cavitatory lung lesion, so in that patients, the sensitivity is going to be relatively higher compared to non-cavitatory lesions. So these are some of the important points that you have to note about the sputum smear testing. And what about the molecular tests? Molecular tests have now become the norm in many areas, but we have two types of molecular tests. One is called the GeneXpert, that's called the Expert MTB RAF, or famously referred to as something called a CBNAT. That's called a cartridge-based nucleic acid amplification testing. So, or simply we can use the term GeneXpert from now on. So it has two big advantages. Number one, the testing is extremely rapid. That means the result can be dispatched within 2 hours. Next, it also detects rifampicin resistance. This is again a major advantage of this particular test because smear can't test anything, obviously. You know that. At least something is better than nothing. It detects rifampicin resistance at least. But remember, again, I can tell this point in a different way. It detects only rifampicin resistance. That's also something should be taken as a guarded sentence. And what are the other features? For example, the samples you have to know. So what are the samples that can be tested with GeneXpert? The first sample is the sputum sample. We all know that. The second one is the FNAC samples. Anywhere you take FNAC, you can send for GeneXpert, but very, very good if the sample is coming from a lymph node. It's one of the best samples. FNAC from the lymph node is one of the best samples for GeneXpert. And number 3, you can also take it from the CSF. Remember, CSF is the only fluid where GeneXpert is recommended. For pleural fluid, pericardial fluid, and ascites and all, we generally don't use GeneXpert because they're extremely poor yield. But CSF, WHO as well as RNTCP is recognizing this GeneXpert as a first-line diagnostic test in patients who are having suspected tuberculous meningitis. So in those samples you can use. Next, apart from this is the first-line diagnostic test in HIV patients and children. This is the first line for presumed pulmonary TB also. Because for adults, presumed pulmonary TB, first-line test is your sputum smear examination only. But in HIV patients and children, you cannot use sputum smear samples because of the extremely low sensitivity. So we are going to use this GeneXpert only as the first line. And you can see the sensitivity and specificity in various cases, like what will be the sensitivity and specificity of GeneXpert in smear positive, and what will be the sensitivity and specificity of GeneXpert in smear negative cases. Sensitivity is 98% in smear positive and 99% specificity. Again, the specificity is 99% in smear negative case also, but it's very important to know the fact that the sensitivity in smear negative cases is 70%. You have to take it in a positive note. Why? Because even in a smear negative patient, GeneXpert can detect additional 70% of the cases. So that is the biggest advantage. So that's why you have to take it as a positive. And second one, what I'm going to discuss is on the line probe assay. That's called an LPA. This is also referred to as something called a genotypical MTB. Genotypical or genotype MTB drug resistance plus, DR plus. And again, line probe assays are relatively faster, which means the results come in less than 1 to 2 days, maximum within 72 hours usually, and uses probes to detect the bacteria as well as the resistance. But big advantage is it can reliably detect the rifampicin resistance as well as isoniazid resistance. It's very reliable for these two resistances. It can also actually detect fluoroquinolone resistance and resistance to second-line injectable drugs. We call them as SLIDs, second-line injectable drugs. But the sensitivity is very poor. So sensitivity for detecting fluoroquinolone resistance is only 80%. For second-line injectable drugs, it's hardly 75% sensitivity. But for detecting rifampicin resistance and INH resistance, it's having a reasonably good sensitivity. So I can also tell you one more point. Rifampicin resistance is detected by identifying a genetic mutation called RPOB gene mutation. Clear? Similarly, the INH resistance is detected by identifying the two mutations called CATG gene mutations and INHA gene mutations. Both are detected. So this is how they detect the rifampicin and the INH resistance. But even more digging to the core process, your sensitivity for detecting actually rifampicin resistance is more than the INH resistance. Similarly, the specificity for INH resistance is more than the rifampicin resistance, which means detecting rifampicin resistance has more sensitivity. Detecting INH resistance means high specificity. So this is some of the small differences that you have to know. But apart from that, this is a very important test, line probe assay. Then finally, you have this culture testing. You have two types of culture testing, I told you. One is called this traditional solid medium, that is otherwise referred to as a Levenshtein-Jensen medium. Traditional solid medium, that is otherwise referred to as something called a Levenshtein-Jensen medium, LJ medium. And this is absolutely obsolete and it is not at all recommended by any guideline, including WHO as well as by RNTCP guidelines, because the results may take up to 84 days to come. So we're not going to use them anymore. But currently we are moving down to liquid cultures. Liquid cultures. Liquid cultures, you have two types. One is called semi-automated cultures. The semi-automated cultures are referred to as BACTEC 460 TB, and this is again is outdated. We are not using this anymore, semi-automated. But currently, what we prefer is the automated liquid cultures. These are referred to as ALCs, automated liquid cultures, and this is what is endorsed by WHO as well as RNTCP, and this is considered to be the gold standard for diagnosing any tuberculosis. Growth in automated liquid cultures. The typical method what we use is the BACTEC MJIT 960, and this is the gold standard as of the current era according to RNTCP, where the results for positive test can available within 2 weeks, but the results of a negative test might take approximately 6 weeks. That's what you have to know. The results of a positive test, if the bacterium is growing, then it will be available within 2 weeks. But if the bacterium is not growing, it may take up to 6 weeks to confirm the negative result. But still it is 6 weeks max, which is almost half the duration of your solid culture, 84 days. At the same time, if it's a positive test, it's extremely rapid. Within 2 weeks, you will get the growth as well as the sensitivity pattern also. It's so good, isn't it? So that's why this automated liquid cultures are preferred by RNTCP and WHO. At the same time, two other methods are there. These are variants that's called a Versatrec. And second one is the BACT-ALERT. So these are also very, very similar to the MJIT 960, and with some modifications will be there. That's all. Okay, suppose if the culture is coming as positive, suppose you are encountering a positive culture with ALC. So what are you going to do? Definitely you have to subject to DST. That is, drug sensitivity testing has to be done in these patients who are having a positive culture. The same bacteria has to be subjected to drug sensitivity testing. The method what we use is called proportional sensitivity testing, PST. The method of DST, what we do is the PST, that's called proportional sensitivity testing. But remember, this drug sensitivity, if they are subjecting the reports to come, it might take additional 2 to 3 weeks. And one biggest advantage is it can detect both first and second line drug resistance and sensitivity reliably. Not like line probe assays where the fluoroquinolone and second line injectable drug resistance testing will be unreliable. But here it is absolutely reliable. So this can be used for monitoring treatment also, because it can differentiate between the live and the dead bacilli. So it can be used for monitoring treatment, but your sputum is little bit unreliable for monitoring treatment. At the same time, your GeneXpert is also a little bit unreliable for monitoring treatment. Your molecular tests are also unreliable because these two cannot differentiate between living and dead bacteria, but this can be used for monitoring treatment response. So these are some of the aspects of the culture. So these are things you have to note about the culture also. So then after knowing the cultures, we'll start knowing about the other diagnostic tools. What are the other diagnostic tools? Clear? So number one is the chest X-ray, very commonly used test in India. Using a chest X-ray along with sputum. Suppose you are using a sputum along with chest X-ray, definitely will increase the sensitivity because you're using two screening tests. Because the chest X-ray itself is a independent screening tool. Obviously, in PSM, we would have studied any two screening tests are added, the sensitivity will increase. At the same time, the negative predictive value also will increase, but the specificity will drop. So that's what I'm trying to tell. Since you are using two sensitive tests, since chest X-ray is also an independent screening tool, adding together will increase the sensitivity for sure. Then certain chest X-ray findings itself can be taken as TB unless proved otherwise, which means certain chest X-ray findings itself will be diagnostic. Best example for this will be if the patient is having a upper lobe cavity with consolidation. So especially if they have a history of contact with TB and all, this finding itself may be sometimes taken as a confirmatory for tuberculosis. If you do like this based on some investigation, but you're not doing a microbiological confirmation, remember all these three tests, smear, molecular test and culture, all they do microbiological confirmation. All of them can do microbiological confirmation, which means you are microbiologically confirmed that the bacteria is present. But other diagnostic tools, what I'm going to tell now, they do not offer microbiological confirmation. They're not going to offer microbiological confirmation. And if you are going to confirm TB by any of these methods, what I'm going to tell from now on will be put under an entity called clinically diagnosed TB. So you cannot confirm microbiologically, but you will be just calling it as a clinically diagnosed TB. For example, this one example where a patient with a history of contact with TB having a upper lobe consolidation with a big cavity. Obviously, I'll be taking as a tuberculosis unless proved otherwise. And if you start treating with ATT for this patient, means it's going to come under a category called a clinically diagnosed TB. It's not a microbiologically confirmed TB. So you have to be very sure. Microbiologically confirmed means that test which I told now, the cornerstone 3 tests, smear, culture or molecular test, any of them should be positive. Otherwise, it will be clinically diagnosed TB only. So then you have serological tests. Please note that the serological tests, as I told you in the beginning, first video in the pathogenesis itself, Mycobacterium tuberculosis does not stimulate production of any valid antibodies in the body. So that is the reason the serological test, which was once available, was completely banned by the government of India. If you use serological test for diagnosis of TB, I told you it's an offense. You cannot do that because this was banned by government order in June 7th, 2012. I think this correct number, June 7th, 2012, they banned this serological test. No longer you can use the serological. This is a gazette notification. You can't do that. And WHO also has clearly told there is absolutely no role for serological testing in India or any of the country for that matters. Number 3, some other tests you can use like urinary lipoarabinomannan, LAM. This I have discussed in the previous video in the urogenital TB, where I told you if the patient is having suspected urologic TB, plus if the patient is HIV, then you can use this test. That's called urinary lipoarabinomannan, but we don't know whether to use in HIV negative patients or not. Only in HIV positive patients this is validated. In HIV negative patients, this test becomes unreliable for detecting the same urologic TB. But HIV positive patients, this urinary lipoarabinomannan is very, very effective test for diagnosing tuberculosis. Number 4, we have a lot of immune-based tests. These are not serological tests, but there are immune-based tests. We know there are 2 testing available for this immune-based test. One is the tuberculin sensitivity test, and second one is the interferon gamma release assay. Both the mechanism is almost similar, but what we test is different. One is a skin-based test, another is a blood-based test. That's all. So first, let us see the differences in the form of mechanism first. Mechanism is going to be very similar to each other. First, you are making the patient getting exposed to a TB antigen. So both IGRA as well as your purified protein derivative, that is tuberculin sensitivity test. In TST, you are going to use a compound called PPD. Sometime back only I told you that's a purified protein derivative. This is going to contain more than 200 antigens that are shared between different species of mycobacteria like Mycobacterium tuberculosis, Mycobacterium bovis and non-tuberculous mycobacteria. But here, you are going to use only 2 TB specific antigens. Relatively TB specific antigens. One is called the ES86 and second one is the CFP10. So these are the 2 TB specific antigens that we are going to use in IGRA. So anyway, we are going to make the patient exposed to a TB antigen. So if they are exposed to the TB bacteria already, or if they are not exposed to the TB bacteria already, depending on that, your response will differ. Suppose, let us see whether is there any prior exposure to TB bacteria is there or not. We can write prior exposure to TB is there or not. No or yes. If no means there will be no interferon gamma release because of there will be no activation of the T helper 1 pathway. If they are already exposed to this TB bacteria in the past, there will be Th1 memory cells. We know these are memory T cells will be there, and they will recognize this antigen as soon as possible, and they're going to produce excess amounts of interferon gamma compared to the non-exposed individuals. So this excessive amount of interferon gamma is the key. In interferon gamma release assay, this is directly measured and quantified. Whereas in tuberculin sensitivity test, that is Mantoux test, this excessive interferon gamma is not directly tested. Instead, it is indirectly tested in the form of, because they are going to produce vasodilation. Along with that, they'll cause recruitment of inflammatory cells to the inflamed area. So because of vasodilation and recruitment of inflammatory cells to that particular area, they will result in induration. And they are going to measure the induration. So more the induration, more is the interferon gamma release, which means more is the chance that the patient would have exposed to TB already. Clear? So both the mechanism is very simple. You are finding out the interferon gamma release. That's all. But how you find out is different. In your IGRA, you are finding out the actual interferon gamma levels. But whereas in tuberculin sensitivity test, you are measuring the induration. The Mantoux test, you are measuring the induration. That's it. It's very important to measure the induration and not the erythema. Remember, usually this is tested after 48 to 72 hours, typically, because all this process will take approximately, to get the induration and to measure the induration, appropriate time is 48 to 72 hours. The amount of PPD that is injected will be 0.1 ml approximately. That should be done intradermally. All these points are also important. Intradermally it will be done. And induration should be checked approximately around 48 to 72 hours. And why I'm telling this point, induration means because this is the induration here, and this is what you should measure. And it sometimes you can falsely measure the entire erythematous area, and here you should not measure the erythema. You should measure only the indurated area. That is the correct measurement. Clear? So this is how you are going to measure. This is the actual tuberculin test or the Mendel-Mantoux test. But what are the advantages and disadvantages? Remember, one of the biggest advantages of tuberculin sensitivity test is the fact that we have a huge experience. Almost more than 100 years of experience is there. This becomes the disadvantage of IGRA, poor experience, and we don't know how this test is going to work in different communities, which means less than 10 to 12 years of experience is there. It's not a good experience. But tuberculin test, definitely more than 100 years of experience we have. And next, advantage of IGRA and disadvantage of Mantoux test. Mantoux test can be false positive. It can be false positive in a patient who is already BCG vaccinated, point number 1, and any patient who is infected with non-tuberculous mycobacteria. In both these instances, it will be false positive. But that's a big advantage of IGRA, where BCG vaccination will not lead to false positive, no false positives. But false positives can happen with non-tuberculous mycobacteria, but it is extremely limited. Extremely limited, only with a few species it will cross-react. Otherwise, you will not get the false positive. What are the few species that can cross-react? One is Bovis, second one is Kansai, and third one is Sulgai, and fourth one is Marinum, and fifth one is Africanum. So these are the only species that cross-react with IGRA for TB. Apart from that, there is no much cross-reaction. But here, every single type of non-tuberculous mycobacteria will give a positive result in tuberculin sensitivity testing. So that's one of the big negatives of this test. That is the reason why in your developed countries and all, especially where everyone is BCG vaccinated, they always prefer interferon gamma release assay. But the problem is, this test has been validated this test has been validated in low prevalence nations where the TB prevalence is low. But it is not validated in high prevalence nations. But this tuberculin sensitivity testing has been validated. The Mantoux test has been validated in high prevalence countries like India. So that is the reason why RNTCP currently endorses only the use of TST. RNTCP does not endorse the use of IGRA because the validity of this test is unknown in high prevalence nations like India. At the same time, we have no idea, and the cost is also very high. So that is the reason currently we prefer only India. RNTCP prefers only use of Mantoux test, that is tuberculin sensitivity testing. Okay. Next, your Mantoux test also can produce a phenomenon called booster phenomenon, where this will not happen in case of a IGRA. Booster phenomenon is not a feature. So what do you mean by a booster effect or a booster phenomenon or a boosting phenomenon? Let us assume a patient initially is having a tuberculin negative test. TST is negative. Again, you are repeating the test after some time. Now the tuberculin reaction will increase and the test may even become a positive reaction. So this is called a booster effect. Actually, this is a false positive response because of recurrent testing and recurrent exposure of the PPD and the antigens to the body. So this is something like, you can imagine like a false, but this is not a true positivity. So suppose if you do the first TST and if you do a second TST within a short period of time, the second TST might become positive, or it might at least show increased in duration compared to the first one. It may not become positive, but at least it will show increased in duration compared to the first test. So what is the time interval that is very notorious for causing this booster phenomenon? That is the second test being showing increase in duration or becoming positive. Typically, if you do the test within 1 to 5 weeks mark, so this is the notorious time interval. If you repeat the TST within this 1 to 5 weeks mark, there's a lot of possibility that you might end up with a increased amount of induration and the TST might become falsely positive. So that is, one more important thing is, if you do within 48 hours or if you are doing after 60 days, the TST is unlikely to show this booster phenomenon, which means unlikely to have increased in duration or a positive response with the second test. But if you do within that 1 to 5 weeks mark, especially from 1 week, starting from 1 week to the 5 weeks, that time gap is very, very notorious for causing a false positive reaction or a falsely increased in duration because of the anamnestic response. That is what we refer to as the booster phenomenon. Clear? Whereas this booster phenomenon is not a feature of your interferon gamma release assay. Again, this is a very, very important advantage of interferon gamma release assay. And next disadvantage of tuberculin sensitivity test is it needs 2 visits, which means patients should come for a follow-up to measure the size of the induration. But here you need only 1 visit, which means the complaints will be more. You need just 1 visit, that's all. There is no need for coming for follow-up on it. The result will be dispatched automatically. And one more problem is this Mantoux test can be false negative also. There are a lot of conditions where Mantoux test can be false negative. First, whenever the T cell response is low, in any patients who are having a reduced T cell response, like severely immunocompromised patients, especially HIV patients or patients on long-term steroids, cancer chemotherapy patients, all these patients will have false negative test. At the same time, patients may be malnourished or very elderly patients. They may have a reduced T cell response because of the test may be negative falsely. At the same time, recent measles. This is a multiple times asked question. If the patient is having a recent measles infection, and this recent measles will induce an energy, and this can produce a falsely negative test. If they ask you how long you should delay the TST, how long you should delay the Mantoux test, if you have got a recent measles, it should be delayed by at least 4 to 6 weeks. Clear? You should delay the test by at least 4 to 6 weeks if the patient has got a recent measles. And second thing is, even after MMR vaccine, even if the child has received an MMR vaccine, for the same duration, you have to delay doing the tuberculin sensitivity test. For the same duration. even after an MMR vaccine, because it's like a measles infection only. So these are some of the important points that you have to know. Even sarcoidosis, because of the peripheral energy, you might get a negative tuberculin sensitivity test, because obviously I told you know, in the sarcoidosis there will be an immune paradox where there will be central immune activation with peripheral energy. We have discussed already. So these are some of the important things that you have to note about the tuberculin sensitivity test and Mantoux test. And this tuberculin sensitivity test is also referred to as, I told you already, something called a Mendel-Mantoux test, isn't it? This is what we refer to as something called a Mendel-Mantoux test. Clear? Fine. And you have to know everything in and out about TST. So when you will consider positive, TST as positive, it depends on the size of the TST positivity. So based on the diameter, when will you consider positive? In certain population, even more than 5 millimeter is considered positive. What are the population? HIV patients, number one. Second, any immunosuppressed patient, especially who are received organ transplant, who are having cancer and receiving chemotherapy now. Any significantly immunosuppressed patients, definitely anything more than 5 millimeter itself is significant. Then patients who are having signs of TB on chest X-ray. For example, there is a cavity, even 5 millimeter, I'll take it as a positive response only, because there's no need for them to wait for the 15 or 20 millimeter, because I have already the signs of tuberculosis. Next, if the patient is having a history of recent close contact with tuberculosis, recent close contact with tuberculosis infected individual, or an active case of tuberculosis. In these patients, I can even take 5 millimeter as a positive test. But most important is these two areas, especially the HIV is the most important. That is the one they will ask regularly in exam. In HIV patients, just 5 millimeter is enough to take the Mantoux test as positive. Where you can take more than 10 millimeter as positive, in patients who are having high risk of reactivation. What are the patients who are going to have high risk of reactivation? Number one, if the patient is an intravenous drug abuser. Second, homeless patients. Third, if the patient is having any kind of chronic illness like diabetes, chronic kidney disease, chronic lung disease, CCF, congestive cardiac failure, these patients, chronic illness, any chronic illness, these patients also 10 millimeter itself can be taken as a positive test. Children less than 4 years, 10 millimeter can be taken as a positive test. Or patients who are at high risk of occupational hazards, like healthcare workers especially, or those who are living in prison, which means there is high chance of reactivation in these patients also. So in these patients, even 10 millimeter you can take it as a positive test. More than 15 millimeter, this is highly positive. Many times this 15 millimeter plus reaction may be associated with partial blistering kind of reaction also. It's a very, very positive test. So which means any time when you have more than 15 millimeter, it is considered as always positive. Whether or not the patient has risk factors, is HIV or not, no HIV or not, immunocompromised or not, competent or not, doesn't matter. This 15 millimeter is the maximum cutoff. Anything more than 15 millimeter is definite positivity. It is surely positive only, irrespective of the risk group. So this is what you have to know. So where you will take it as positive. But remember, only 3 things I want you to know. One is HIV patients, more than 5 millimeter itself is positive. And second, IV drug abusers and children less than 4 years, 10 millimeter itself can be taken as positive. And any chronic illness, more than 10 millimeter can be taken as positive. And anything more than 15 millimeter, irrespective of the risk factors, it is always considered to be positive. So these are the interpretations of the induration in the Mantoux testing. Clear? Let us see some of the diagnostic algorithms given in the current RNTCP guidelines. First, let us go for the presumed pulmonary TB case. One of the side points that you have to know in a presumed pulmonary TB case is the fact that all patients with presumed pulmonary TB should be offered with HIV testing. All patients. It's up to them to do. You cannot force them anyways. So in a patient with a presumed pulmonary TB, how you are going to evaluate the TB? That's what is important here. You are going to get 2 samples. Get 2 samples from the patient. In that the guidelines suggest that both can be on-spot samples, not a problem, or one can be on-spot plus another one can be early morning sample. This is what is preferred actually. But if you feel that the patient may not turn back again, you can get both the samples on spot also. That is to avoid the loss of follow-up. That is why. So anyway, 2 samples will be obtained. In that, the first sample will be subjected to smear. First sample will be subjected to smear. Along with that, you will be doing a chest X-ray also. This is step 1. But there is a very, very important exception to that. This first sample smear rule, there is a very important exception. This first sample should be sent to gene expert. Suppose if the patient is having HIV, or if the patient you're dealing with is a pediatric age group, or if the patient is already having an associated extrapulmonary TB. In this setting, definitely you have to send the first sample itself for gene expert only. There is no role for doing a smear in the first sample. So that's a very important exception. So now compile the results. You can compile it into 2 ways. One is smear positive cases and smear negative cases. The patient is a smear positive finding is coming. Then in those patients, you can straight away put them as microbiologically confirmed tuberculosis cases. This is the microbiologically confirmed TB. Easy. But further testing is not required unless and until the patient is a presumed drug-resistant TB. If the patient is a presumed drug-resistant TB, then you have to offer further drug sensitivity testing, either in the form of LPA or maybe you can do in the form of a automated liquid cultures also. You can perform the drug sensitivity testing there. But remember, what our goal for 2020 to 2025 is 100% all the patients should be offered drug sensitivity testing. Irrespective of the presumption or not, all the patients should be offered DST. That's the goal. But right now, we are offering this DST only for presumed drug-resistant TB cases, that as per the 2017 guidelines. So smear negative. If the patient is smear negative, see the chest X-ray results. Chest X-ray may show abnormal findings, or chest X-ray may show normal findings. So the chest X-ray is abnormal. The second sample, what you have obtained, will be subjected to your gene expert now. At the same time, you will do the smear again in the second sample. So now the results of CBNAT will come. What are the results of this gene expert? Gene expert is the one that we're going to look for here. The gene expert result may come as organism is detected, or it can come as organism is not detected. If the organism is not detected, it's very unlikely to be having tuberculosis. But not 100% sensitivity though, because if the smear is negative, you know very well that the sensitivity of gene expert is only 70%. So in these cases, either you consider alternative diagnosis, or you can consider some possibility called a clinically diagnosed TB. That entity is also valid. Clinically diagnosed tuberculosis, especially if your classic chest X-ray findings are there. Like for example, if you have a typical upper lobe cavity with consolidation, the patient's symptoms are very typical. So in those conditions, you can make a diagnosis of a clinically diagnosed tuberculosis also. That is also there, but depends on the clinician. But one problem with this clinically diagnosed tuberculosis is it will lead to overdiagnosis and missing of some other diagnosis also. But since we are approaching towards the NTB campaign, so sometimes overdiagnosis and overtreatment is acceptable. That's what these guidelines are indirectly telling that only. So that's why we are doing something called a clinically diagnosed TB, even though you don't have a microbiological confirmation. Suppose if the MTB is detected here, again it's very simple. It is simply considered as a microbiological confirmed TB only. There's no doubt about that. These patients are definitely microbiologically confirmed tuberculosis. Suppose what if the chest X-ray is showing a normal finding? Then here the likelihood of TB is usually very low, but still you can consider the likelihood of tuberculosis, or a suspicion of tuberculosis. If the likelihood of tuberculosis is very, very high, then again you can perform the GeneXpert and the smear in the second sample and you can compile the results once again. Or if the suspicion is very, very low, the suspicion for tuberculosis is very, very low, then you can see very clearly the smear is negative, the chest X-ray is normal, and the likelihood of TB is also very low, means definitely here it's better to consider alternative diagnosis. It's very, very unlikely in these patients to have a tuberculosis. Consider alternative diagnosis. Clinically diagnosed TB can be an entity, can be a possibility, especially if your chest X-ray is abnormal. In these conditions, you can make a possibility of at least a clinically diagnosed TB, but if the chest X-ray itself is normal and the smear is negative and the likelihood of TB is also low, means it's very, very unlikely that you can diagnose a clinically diagnosed TB in this setting. So that's why I told you always consider alternative diagnosis in this setting. Cool. So this is the idea. Fine. So all these things we have mentioned. So how much sputum you have to get at least? As per the guidelines, the amount of sputum you have to get is also there. It should be at least 2 ml of sputum and it should be mucopurulent. It should be mucopurulent and at least 2 ml is mandatory. Clear? For proper diagnosis. Then we have another entity called a presumed extrapulmonary TB. That's called a presumed extrapulmonary TB. This is a second entity. How you are going to approach this presumed extrapulmonary TB? Whenever you have an extrapulmonary TB, your goal is to obtain an appropriate specimen from the intended site. For example, lymph node is very easy, but sometimes it may be difficult if you are having a celiac node and suspected TB there. It's very difficult to get sample from there. Suppose the idea is very simple. Whatever may be the site of extrapulmonary TB, your idea is to, or goal is to obtain an appropriate sample from the site or appropriate specimen from the site. So sometimes it may be easily available or sometimes it may not be available. Sometimes because of some sampling issues and high risk reasons, you may not be able to get a sample from a particular area. For example, we had a case which looked like definitive TB in the cervical spine. It's a very, very rare case. We have never encountered that in my life. Only 2 cases I have seen. In cervical spine, there was suspected TB and actually it was a confirmed case also after that. But when we wanted to take a biopsy from that area, it was absolutely impossible because the lesion was extremely close to the vertebral artery. And the radiologist told it's impossible to get the sample from that particular area. So we proceeded with other diagnostic methods and then only we confirmed it's a tuberculosis. So like that, you might be having a lot of issues where your sample may not be obtainable, especially in case of a extrapulmonary tuberculosis. And what you're going to do in these conditions. Suppose if your sample is available, I'm going to do the GeneXpert only. Obviously, for any extrapulmonary TB, it's always better to do better to subject the samples to a GeneXpert. But whether GeneXpert can be done or not, that is also a question. GeneXpert can be done or cannot be done. Suppose if GeneXpert cannot be done, what could be the reasons that GeneXpert cannot be done? I told you for pleural fluid, pericardial fluid, and ascitic fluid and all, GeneXpert is sometimes cannot be done in the first place. And certain samples like solid specimens, FNAC specimens are fine, you can send for GeneXpert. If in case it's a solid specimen, you cannot process for GeneXpert. So that's why you have to see whether GeneXpert can be done or cannot be done. So now GeneXpert can be done or GeneXpert cannot be done. GeneXpert can be done means fine. You are just running the sample in the CBNAT and GeneXpert and finding out whether M. tuberculosis is detected or not detected. If M. tuberculosis is detected by GeneXpert, you know very well you are going to brand this patient as a microbiologically confirmed tuberculosis case. If GeneXpert cannot be done, these patients, you have to do some alternative strategies like automated liquid culture, or you can do an AD and find out it's a clinically diagnosed TB. But anyway, here, if it's possible, especially for solid biopsies and all, I'll be subjecting this to automated liquid cultures, ALC. Suppose if the culture is positive, again, I'll be calling this as microbiologically confirmed tuberculosis only. And if suppose ALC is negative, clear? So in this condition, I have to see the suspicion for tuberculosis. Suspicion for tuberculosis. Clear? Now, I told you if the appropriate specimen is not available from the site, these patients also, I have to see the suspicion for tuberculosis. If suspicion for tuberculosis is low or suspicion for tuberculosis is high. If low suspicion, you have to try considering alternative diagnosis. That's better. If the suspicion of tuberculosis is extremely high in this scenario, then I can try to diagnose by alternative diagnostic tools. I'm going to use a different diagnostic tool, and I can even try to label these patients as a clinically diagnosed TB. So what are some examples where I can do clinically diagnosed TB in this setting? So now my biopsy is not available, or if my biopsy is available but the cultures, gene expert, all these things are negative. Clear? So in this setting, what I can do, for example, if you're strongly suspecting a TB in a lymph node, but your gene expert is negative, but they are showing characteristic caseating granulomas. So I can directly diagnose tuberculosis in this setting. Clear? This is a clinically diagnosed TB. Even though I don't see the organism here, this caseating granulomas means I'm dealing with the tuberculosis. Fine. Or second area, I am having a pleural fluid. This is sign of an extrapulmonary tuberculosis only. Or if I am having an ascitic fluid, or I am having a CSF, where in these two fluids I cannot do a gene expert. Usually gene expert is not done. CB NAT is not done. Plus tissue is not available. Pleural biopsy or peritoneal biopsy is not available. Similarly, in CSF, your CB NAT is either not done or negative, because in CSF you can do the CB NAT, gene expert. So, or if it is negative, in those settings, I can do an ADA testing. If it is more than 40, I can diagnose a TB, tuberculosis. This is what we refer to as another example of a clinically diagnosed TB. So this is how you have to understand. This is what we call a clinically diagnosed TB. If you have diagnosed by non-microbiological methods, alternative confirmatory techniques, it's not confirmatory, but microbiological technique is the confirmatory technique. But if you are diagnosing by alternative methods, apart from microbiological confirmation, that is what we define as something called a clinically diagnosed tuberculosis. You can do that. Yes, still this method is highly valid only according to the guidelines. Suppose I told you if MTB is not detected, what you will do? If MTB is not detected, again you will go back to the same algorithm only. Suppose the MTB is not detected here in gene expert, again you are going back to the same suspicion. If the suspicion is high, you can consider alternative diagnostic tools like ADA or your biopsy showing this granulomatous lesions or caseous necrosis. These are all you can use to assess and treat the patient as tuberculosis, called as clinically diagnosed tuberculosis. But remember, the guidelines clearly tell you should try to obtain sample as much as possible. You should not just like that tell sample is not available. You have to give your every single try to obtain the sample. Then only you have to proceed further for presumed extrapulmonary tuberculosis. This is a little bit complicated, but I have simplified it as much as possible. Now, you have a presumed extrapulmonary tuberculosis. Presumed pediatric tuberculosis. So, we are going to manage a presumed pediatric pulmonary tuberculosis or pediatric TB. So, I already told you in a presumed pediatric pulmonary tuberculosis, straight away the first sample should be gene expert only. There's no doubt. The first sample itself, you should give it to the gene expert. So in some centers, gene expert may not be available. In some centers, it may be available. So if the gene expert is available, see whether Mycobacterium tuberculosis is detected or not detected. If it is detected, you know very well, I'm going to brand this patient as a microbiologically confirmed tuberculosis. Simple. And if the gene expert is not available, these patients, the sample can be subject for sputum microscopy. If sputum smear is positive, then again I can brand these patients as microbiologically confirmed tuberculosis. There are three possibilities are there. Now, if the MTB is not detected, or if the sputum smear is negative, or if the sputum is unavailable, the child is not able to get the sputum. Very common scenario. Even adults sometimes are not able to get the sputum. How can you blame the child? If the smear is unavailable, the sputum is unavailable or the smear is negative. So in these settings, you can see two investigations. You can combine and see, that is called a tuberculin sensitivity test and chest X-ray. Both can be done, TST and chest X-ray. So based on the chest X-ray results, you can compile the results again. Chest X-ray is highly suggestive of TB. Highly suggestive of tuberculosis. When you call the chest X-ray is highly suggestive of tuberculosis, what are the findings as per the RNTCP? One, if you have a miliary shadows, definitely, like in India, miliary shadows is equal to tuberculosis unless proved otherwise. Second, if the patient is having a hilar or mediastinal lymphadenopathy, especially a child having this is definitely a tuberculosis, very likely, hilar and mediastinal lymphadenopathy. Or if the patient is having a chronic, if the child is having a chronic fibrocavitary lesions. Fibrocavitary lesions. So these are some of the patterns according to RNTCP that are highly suggestive of tuberculosis. Okay, if that is the case, then these patients may be subjected to gastric aspirate or induced sputum. Normally, we induce sputum with certain mucolytic drugs, like you can induce with 3% hypertonic saline, or you can induce with your N-acetylcysteine, that is mucomist nebulization. All these things you can give, and you can do something called an induced sputum. And this you can subject it to gene expert once again. Clear? Either the gastric aspirate or the induced sputum can be subjected to gene expert. And now it can come as not detected, or it can come as detected. If it comes as detected, you know very well, it will be a microbiologically confirmed tuberculosis. If it's coming as not detected, then you have to consider either alternate diagnosis, or you can even go for a diagnosis called clinically diagnosed TB. Why you can consider clinically diagnosed TB here? Because very simple, the chest X-ray is so suggestive of a tuberculosis. In those conditions, remember, gene expert sensitivity is again limited, especially if the smear is negative. I told you already. So it cannot detect 100% of the case at all the time. So gene expert negativity doesn't mean definitely TB is not there. It is not the gold standard. Be careful. So that is why you can sometimes make a diagnosis of clinically diagnosed TB if the chest X-ray is highly suggestive of tuberculosis. Okay. What if the chest X-ray is normal? So if the chest X-ray is normal, then I will be seeing the TST results, because I have done already the tuberculin sensitivity test, MANTO. So if I see the TST, if the TST is negative, strongly I will be considering alternative diagnosis only, because smear is negative, chest X-ray is normal, TST is also negative, very unlikely to be tuberculosis. So consider an alternative diagnosis. If the TST is positive, in this condition, you can either consider alternative diagnosis, or you can even consider a extrapulmonary tuberculosis in this. Why? Because the chest X-ray is normal, but TST alone is positive, means there might be a possibility of extrapulmonary tuberculosis also if the child is symptomatic, like night sweats, weight loss, and all these classic symptoms of TB, constitutional symptoms are there, but the chest X-ray is normal and the smear is negative. In those conditions, you can consider extrapulmonary TB also. Clear? So possible. So what if the third possibility, chest X-ray is showing non-specific shadows? Non-specific shadows. That's also possible. According to RNTSP, what are the examples of non-specific shadows? If you have consolidations, typically, or if you're having a pattern of a bronchopneumonia, or if you're having some non-homogeneous shadows. Non-homogeneous shadows. So these are the patterns that are not specific for tuberculosis, but it can be seen in tuberculosis sometimes. I told you tuberculosis can cause any type of radiological picture. In this, I'll be giving a course of antibiotics. Course of antibiotics to see whether the shadows are clearing or not. Suppose if the shadows are not cleared, no clearance, shadows are not cleared, then I'll be going for gastric aspirator, induced sputum, and I'll be sending that for gene expert. Suppose if the shadows have cleared, that's why I'm writing in green, shadows have cleared completely, then please consider alternative diagnosis. But very, very important fact is the point that this antibiotic what you are giving should not have anti-tubercular activity, anti-TB activity. Very, very, very important, this point. Suppose if you are giving an antibiotic that is having anti-TB activity, means your shadows might clear and you might be unnecessarily considering alternate diagnosis in a patient who is already having a TB actually. So give an antibiotic that is not going to have an anti-TB activity. So example of antibiotics that you should not give. What are the examples? Typically fluoroquinolones you should not give, because most of the fluoroquinolones have good anti-tubercular activity. We'll be seeing the treatment where I'll be telling fluoroquinolones is one of the excellent anti-TB drugs, second line drugs, but then you should not use amoxiclav. Augmentin should not be used. And you should not use this linezolid also. All these drugs have anti-tubercular activity to an extent, especially fluoroquinolones. Definitely you should not give. Anyways, in children less than 8 years, fluoroquinolones will be avoided because of risk of Achilles tendon rupture and tendinitis. So you should not give anyways. So this is the goal. And what are the antibiotics that you can give? You can put a tick mark. What is, possibly you can give. One is clindamycin and macrolides, definitely indicated. So this does not have any anti-tubercular activity at all. So definitely you can prefer using these antibiotics instead. So if it's clearing, then definitely it is not a TB, unlikely to be a TB. So consider alternative diagnosis. So this is how you evaluate a presumed pediatric TB. So this is very elegant and simple algorithm which I have mentioned. And we're going to see how will you manage a presumed drug-resistant tuberculosis. How you are going to manage a presumed drug-resistant tuberculosis. In the sense, like any presumed drug-resistant tuberculosis patient has to be offered drug sensitivity testing, which means the first step in offering drug sensitivity testing is LPA, that is line probe assay. This line probe assay can detect both isoniazid as well as rifampicin resistance. That's the big advantage. At the same time, we also have to know the fact that if a patient is having rifampicin resistance in your gene expert, that is cartridge based nucleic acid amplification test, or if it comes as rifampicin intermediate in gene expert tests for at least 2 times. Twice it's coming as rifampicin intermediate, then these patients also can be taken for drug sensitivity testing through LPA, that is HNR resistance. So now the results of this line probe analysis or line probe assay can be in 2 ways. Either they can come as rifampicin resistant again, or they can come as rifampicin sensitivity. Remember, the moment you know it's rifampicin resistant by LPA for sure, in this step you have to start treating like MDR-TB. So start your treatment like MDR-TB and send the patient for automated liquid cultures. So which means send the sample for ALC, automated liquid cultures, where they will be doing a lot of extensive drug sensitivity testing there. And if the patient is rifampicin sensitive, then you have to see whether INH is sensitive or not. If isoniazid is sensitive, which means rifampicin is also sensitive, INH is also sensitive. So how will you know that? What kind of patients will come to this kind of algorithm? If patients are coming rifampicin intermediate in gene expert for at least 2 times, but now in line probe assay, they have been proven to be having rifampicin sensitivity as well as INH sensitivity, which means this is nothing but a sensitive tuberculosis, which means you are going to just continue your first line ATT drugs for the prescribed duration and discontinue. Clear? So that's all. You're not going to do anything here. The same regime you're going to continue. Suppose if it's going to come as INH resistance, it depends on what resistance you're going to see. Remember, if it's INH resistance, whether it's a CATG gene-related resistance, again this we have seen extensively in the next video in the mechanism of drugs and pharmacology, CATG gene resistance, or it's going to be INHA related drug resistance. If CATG gene related drug resistance means usually there will be high level or high grade resistance to INH, which means in this condition you have to omit INH and you have to continue other drugs, continue other sensitive drugs. Suppose if it's INHA resistance, if INHA resistance, here it's going to be only a low grade resistance, which means in this condition you can continue high dose of isoniazid. There won't be any issue. You can continue high dose INH in these cases. But remember, rifampicin is sensitive, but INH is resistant, which means all INH resistant cases, again you have to take for ALC testing. Very, very important, because if you know it's INH resistant means you don't know what other drugs are resistant. Other first line drugs like pyrazinamide or ethambutol also can be resistant. So you have no idea. So please do ALC testing in this scenario. That is automated liquid cultures for a full drug sensitivity profile. So what ALC does? What ALC is going to do is two types of testing. One is called a preliminary or a baseline drug sensitivity testing. What you're going to get out of this baseline drug sensitivity testing is you're going to get sensitivity of remaining first line drugs. You know what are the remaining first line drugs? Only two are there, that is pyrazinamide and ethambutol, because isoniazid and rifampicin already have tested through line probe assay. So here it's going to check for remaining first line drug, that is typically your pyrazinamide and ethambutol, maybe streptomycin, because streptomycin will come under the aminoglycosides, injectable drug. So anyway, that will match there, so don't worry about that. So first line remaining drug, that is typically pyrazinamide and ethambutol. Next, they are also going to test for fluoroquinolones, clear? And other second line oral drugs. The important second line oral drugs that are checked apart from fluoroquinolones include ethionamide and linezolid. Ethionamide and linezolid. You know the fluoroquinolones that are used in second line drugs are moxifloxacin, levofloxacin, which I have discussed extensively in the next video. So moxifloxacin, levofloxacin are the ones that levofloxacin is very commonly used, but moxi is also used as a second line antitubercular drug. So this is what they're going to test. If they ask you what they're going to test, moxi, levo, ethionamide and linezolid. That's it. Then they also check for the second line injectable drugs. Clear? Second line injectable drugs, there are only two, that is kanamycin and capreomycin. Amikacin is currently out of favor, but kanamycin and capreomycin are the ones that are preferred. So these are the drugs that are tested for sensitivity in the baseline DST. But you can also go for a extended DST. That's called extended drug sensitivity testing. Suppose if any one fluoroquinolone is resistant, or if any one second line injectable agent is resistant, in this condition you have to do a full profile, that's an extended DST, where they are going to test for three important drugs, that is bedaquiline, PAS and clofazimine. You have to test for this. So these are the three drugs that will be tested under extended DST. Clear? So very, very important points, all these things. So what are the sensitivity that's going to be tested under this baseline DST, and what are the drugs that are tested for sensitivity or resistance in the extended DST? All these things are important. And when will you do an extended DST? Indications for doing an extended drug sensitivity testing. Remember, when will you first of all do a line probe assay? When the patient is having a presumed drug-resistant tuberculosis, or in your CB NAT, that is gene expert, if it's coming as rifampicin resistance, or in CB NAT it's coming as rifampicin indeterminate for at least 2 times. Clear? So these are the areas where you have to do this LPA, that is at basic drug sensitivity testing through line probe assay, which tests for both isoniazid as well as rifampicin. Clear? So this is how you evaluate a drug-resistant TB in general. So with this we can complete this particular video, and in the next section we will be discussing on the pharmacology of the antitubercular drugs.